Hi everyone, welcome to today's topic seronegative spondyloarthritis. Seronegative spondyloarthritis is a group of inflammatory rheumatic diseases with common clinical and etiological features, including axial and peripheral inflammatory arthritis, enthesitis, and extra-articular manifestations. Let's have a look into it. Rheumatoid factor is usually negative in these type of spondyloarthropathies. Hence, it's called seronegative spondyloarthropathies. Mainly, four subgroups of spondyloarthritis are distinguished. So, it can be easily remembered by using mnemonic pair. P for psoriatic arthritis, E for enteropathic arthritis, A for ankylosing spondylitis, R for reactive arthritis. So, let's explore each subgroup. First one, psoriatic arthritis. Psoriatic arthritis is a long-term inflammatory arthritis that occurs in people affected by the autoimmune disease psoriasis. So, in 70% cases, psoriatic arthritis will be asymmetric and it affects around 10 to 30% of the people who are suffering from psoriasis. So, in general, psoriatic arthritis is a chronic and progressive condition, occurs approximately 10 years after the first sign of psoriasis. There will be pain, swelling, stiffness, and the affected joint may be red and warm on examination. Different types of psoriatic arthritis. First one is asymmetric type. Two variants are there, oligoarthritis and polyarthritis. In oligoarthritis, less than 5 joints are involved. And in polyarthritis, there will be an involvement of more than 5 joints. The most common type of psoriatic arthritis is asymmetric oligoarthritic type, which usually accounts for 70% of the cases. Next type is symmetric type. As name suggests, it affects joints on the same side of the body simultaneously. It accounts for 25% of the cases. Next is spondylitis. Spine and sacroiliac joints are affected. There will be stiffness of the neck or spine due to the fusion of the vertebral body. Next is DIP predominant, that is distal interphalangeal joint predominant. It accounts for 5% of the cases and there will be inflammation and stiffness in the DIP joints, toes and fingers. Because it affects distal interphalangeal joints, there will be dactylitis or sausage digits and nail abnormalities. Next variant is arthritis mutans. It accounts for 5% of the cases and it is the highly destructive type with extensive erosions. There are some important radiological findings in psoriatic arthritis. First one is penicillin cup deformity. It is due to erosion of the distal end of an interphalangeal joint with bony proliferation at the proximal end, so that it looks like penicillin cup. Another important feature in psoriatic arthritis is fluffy periostitis. Next one is opera glass deformity and telescope fingers. Opera glass deformity is due to folding of excess skin. There is shortening of phalanx and excess of skin is folded transversely and retracted to one another so that it looks like opera glass. Another important feature is ivory phalanx. It is due to increased periosteal and endosteal bone formation. So this appears as increased radiodensity in X-ray. Next subgroup is enteropathic arthritis. These are inflammatory arthritis which are usually associated with gastrointestinal diseases. The GIT diseases which can lead to enteropathic arthritis includes inflammatory bowel diseases which involves Crohn's disease and ulcerative colitis. Next is bypass arthritis which is due to bowel bypass surgery. And then celiac disease, Whipple disease, collagenous colitis and lymphocytic colitis can also lead to enteropathic arthritis. Another important point which is commonly asked in competitive examination is most common extraintestinal complication in IBD, that is inflammatory bowel disease, is arthritis. So arthritis is the most common extraintestinal complication in IBD. Next subgroup is ankylosing spondylitis. It is the most common variant of seronegative arthritis. It is also called Marie-Strumble disease or poker back. Ankylosing spondylitis is linked to autoimmune component HLA-B27. It usually affects the axial skeleton and involves the point where tendon and ligament attached to bone, that is enthesis. It commonly affects the age group 15 to 45 years. Sacroiliac joint is always affected in ankylosing spondylitis. The other diseases which are linked to HLA-B27 can be remembered by using the mnemonic pair. P for psoriasis or psoriatic arthritis, A for ankylosing spondylitis, I for inflammatory bowel disease, and R for reiters syndrome or reactive arthritis. The clinical presentation of ankylosing spondylitis involves fusion or ankylosis in middle or low back, which will lead to bamboo spine or question mark posture. So, bamboo spine or question mark posture is an important feature of ankylosing spondylitis. Systemic manifestations are mainly found in eyes and blood vessels. In eyes, uveitis will be there, and in vessel wall, there will be inflammation which can lead to aortitis and which will further lead to aortic regurgitation. The infections may be the triggering factor for ankylosing spondylitis, especially Klebsiella infection. The most common extraskeletal manifestation of ankylosing spondylitis is acute anterior uveitis or iridocyclitis. The most common extraaxial joints affected in ankylosing spondylitis are hips and shoulders. Important diagnostic features in ankylosing spondylitis includes radiographic findings in sacroiliac joints such as pseudo-widening and symmetric sacroiliitis, and the concavity of the vertebral bodies will be lost, which can lead to squaring of edges in X-ray of spine due to erosion. There will be shiny corner sign due to sclerosis on corners of vertebral bodies. As I already said, bamboo spine is another important feature of ankylosing spondylitis. The involvement of larger joints and the linkage to HLA-B27 are important diagnostic features in ankylosing spondylitis. Next variant is reactive arthritis. It is formerly known as reiters syndrome. Here, there will be a triggering factor, usually a bacterial or viral infection. It is usually presented as sterile inflammatory oligoarticular arthritis occurring 2 to 4 weeks following a remote infection. Most patients aged 20 to 40 years group. It usually follows a urogenital or enteric infection. The common infections which can lead to reactive arthritis involves chlamydia trachomatis in urogenital system and shigella and salmonella infections in intestinal system. The 3/4 of the reactive arthritis are HLA-B27 positive. The clinical triad of reactive arthritis can be easily remembered by using rhyming words can't see, can't be, and can't climb a tree. Can't see means conjunctivitis, can't be urethritis or cervicitis, and can't climb a tree represents arthritis. The complications of reactive arthritis involves enthesitis, which can lead to heel pain and metatarsalgia, dactylitis, which can be presented as sausage digits, cystic balanitis, keratoderma blennorrhagica. So I have tried to cover almost all important points regarding this topic from exam point of view. Hope you find it helpful. Please like, share, subscribe for more videos. Thank you.